in the shoulder, when you know what normal feels like, and so those that are going into PT, AT, even orthopedic surgeons, you do hundreds of these. And you learn what normal feels like, and then when the abnormal ones come, it is clear as day. Okay, but you have to know what normal is first. Okay, so show it on this side. Again, I'm going to brace medial side of the knee, grab the ankle, I'm going to rock it towards me at 0, and then at 30. They both feel symmetrical. Okay?
And when we do that test for the practical, do we need to do both 0 and 30? Or?
Yeah, you do need to do from 0 and 30
okay.
for the varus and valgus. Because it's, the reason why you do it for both is when you have it at 0, for the LCL and also for the MCL, when you have it at 0, you have other structures at play. So you've got your IT band that's going to tighten up when you're at 0. You've got your adductor is going to tighten up for the MCL. So when you put it at 30, it relaxes those and becomes strictly just the LCL and the MCL. Okay, but from a clinical standpoint, if you've got a lot of laxity at 0, you probably have a big problem. You probably have a real big problem. Okay. And so now for the valgus test, to do the MCL, we're going to do the exact same thing, but I'm just going to change my body position. So instead of standing in between and bringing her legs towards me, I'm going to now go on the outside, brace the lateral portion, still grab the ankle, and at 0 and 30, I'm still going to rock the leg towards me. And as you can see, she's a little tighter than she was on the lateral side. Although she's got probably a little bit of hypermobility, would be my guess. So again, brace the lateral side now, grab the ankle, and bring it towards me. Just tight there. Okay. That's all it is. That makes it a little bit simpler, that you're in essence doing the exact same thing, grabbing the ankle, taking it towards the body for varus and the inside, and for valgus, we just shift the body on the outside. Okay?
You do 0 and 30 now.
You do. Yep. Okay, so those are for our collaterals. The next two are for the ACL. So the Lachmann's test and the anterior drawer test. And on the test, on the practical, you'll see anterior drawer test ankle or anterior drawer test knee. Okay, so you're not confused by that. Okay, so the Lachmann's test, the first one, this is considered the gold standard test for the ACL. This is the one that every ortho that you'll ever see is going to do, every athletic trainer, every PT that's going to evaluate a knee for potential ACL tear is going to do this one first. Okay, the whole idea is to replicate the exact same motion that would occur if you were to tear it. Okay, the tibia is going to translate forward, and so you're in essence reproducing the same motion. Okay, the key is to get the knee in a position that's relaxed enough so other structures aren't tightening up to, in essence, compensate for any play at the knee. Okay, first time you do this, I shouldn't even say first time, probably the first 100 times you do this, it's going to be a little bit awkward and it's going to feel like the knee's pretty stable anyways. It's a very subtle test to get, but oftentimes people that are starting to get into clinical rotations, you get about 100 of these under your belt, all of a sudden it just kind of clicks. You get the feel of it, but it does not happen right away. So the idea from this one is just to get the understanding of it. Okay, I'm not going to be real picky on is it moving the exact way, or are you really getting it right? It's more of just getting the understanding, kind of you're trying to recreate the same motion. Okay, and there are some alternative ways to do this because as you see, there's going to be if somebody's got a size issue, large thigh, small hands, it just becomes a little bit more of a challenge to do. So there's some techniques you can do to mitigate that. So perform the test just standard. You can stand outside or inside, doesn't really matter. The whole idea with this, we're going to bring the knee up into about 20 to 30 degrees. Not exact number, it's just in that range. And this gets, again, the position gets the hamstrings loosened up a little bit. When your knee's too straight, you can't move the knee appropriately, so it's not going to work. So you have to have some bend to it. So I'm just going to, with one arm, I'm going to grab the thigh and bring the knee up a little bit. Take my other hand, and I'm going to grab just below the joint line. So I'm going to basically grab the tibia, okay? Because again, we're trying to recreate the same motion. Tibia moving forward is what happens when you tear it, okay? So all I'm going to do then is once I've got that position, and I'm going to try to move that tibia forward, okay? It should be a little tight clump, okay? And what will happen, what will happen is if she tightens up at all, it's not going to move very much. And that's quite normal. They're just not going to feel that comfortable. And oftentimes in the field, when we have one of these, that individual is lying on their side in the fetal position after it occurs, if we're the first ones out there and we kind of recognize that, we do that test, they're pretty relaxed actually at that time. We can usually get a really good test. After that, it gets pretty tough. With a true ACL tear, the knee's going to fuse up. It's going to swell. And so it's going to become very tight. And so even with great form and great understanding, it's going to be still difficult to get the knee to move. So oftentimes orthopedic surgeons, even PTs, have a harder time because they've had more time post-injury. Whereas those that are there right at the time, you see it, and it's probably at its easiest position to be able to test it. Okay.
Can you do it on this side again?
I'll do a couple times.
Okay.
Yeah, I'll do it a couple times. Okay, I just want you to have some understanding with this because there's some subtlety to it. Okay, so let's do it again here. So on this knee, again, grab the femur, bring it up to about 20 to 30 degrees. Grab the tibia just below the joint line. It should be nice, tight move. And again, you can do the same thing if you have hand dominance. So you can do the same thing here. Switch hands. Usually when we're practicing clinically, we usually work on both sides so you have an understanding. I've got an offensive lineman right now that's about 360, give or take some change. Has thighs about half the width of this table. And I can still grab his thigh and still be able to perform it, and because there's some technique to it. Most people probably cannot do that. And not that my hands are really big, or it's just there's some technique aspect to it. So some ways to work around it. Can you hand me that black pillow underneath? And this is what a lot of female clinicians will do. Is just they'll instead of trying to work with hand strength or maybe can't get their hands all the way around, they'll use a prop or something instead. And so one way you can do that is take a pillow and just roll it up, t-shirt, anything, just to get that same bend. And so instead of trying to grab here, you just push that down and brace it against it, then grab a tibia, and you get the same test. Okay? Slide forward. So your knees are hanging off. In a pinch, another way to do it, just have them brace it on your leg like this, hold that down, slide forward. Another way to do it. Okay? The disadvantage of doing those is if the hamstrings tighten up, what's going to happen? It's going to be harder to move because that's going to be working in essence in conjunction with the ACL. So anytime you're doing this test, the hamstrings have to get loose. They have to get relaxed. And if somebody's not cooperating, which post-injury, it's not uncommon. I mean, it's not really their fault. I mean, they may try, but you will definitely run into some that they just will not relax. Okay. And oftentimes with this specific injury, the ortho surgeons, if we got a really good test in the field, and we feel like, yeah, it's pretty well torn, they won't even bother. They just go ahead and evaluate, get the MRI, and move forward. Because they usually recognize 1 to 2 days post, they're probably not going to get a good test anyways. Any questions on that? All right, so let's go ahead and slide back. We do the anterior drawer test, another ACL test. A little bit easier, but limitations. I'm going to bend the knee. I'm going to go ahead and sit on your foot. And all we're going to do, just like we did at the ankle, holding of a drawer. This time I'm going to take the tibia and pull forward like we're pulling a drawer. I usually hit the hamstrings and kind of get them relaxed, grab the tibia, and slide it forward. Okay? You can almost always get the tibia to move. The problem with this test, and the reason why it's not considered the gold standard of it, is what other structures lying next to the ACL? What's behind it? I think I heard it. PCL. So when you're in this 90 position, what happens is as you start to tug on even a torn ACL, the PCL takes up the slack. And so it starts to stop it abruptly, and you get some false readings sometimes when you do this by itself. So it's a good secondary test with the good Lachmann's. Okay? oftentimes we tell our younger staff to focus more on the Lachmann side than this test. Because they'll say, well, I felt something with the drawer test, but they can't corroborate with the Lachmans. I may not be as quick to assume that they've got a tear there. Okay, put this one back down. Here. Just hit the hamstrings and pull. Okay. And again, we're just looking for laxity. So you should, again, a normal test, you should feel like it's going to spring back on its own. When something's torn, it wants to continue, wants to feel like it wants to keep on going. Okay. Next one is the posterior drawer test. Now this is for PCL. These next two are for PCL tests. We don't see a lot of PCLs in athletics, but we do see on occasion, certainly nowhere near the same rate as the ACL, sees a lot more motor vehicle accidents, stuff like that. And again, because PCLs work in conjunction with the quads, they're generally pretty stable in function. So it's not uncommon to have a tear in the PCL isolated and play without any type of surgical intervention at all, because the quads are simply strong enough to withstand the additional movement. So one of the ways to confirm a test is to go ahead and do the drawer test. Same thing as the anterior, except this time we're going to push the drawer back. One subtlety with this, you have to set the knee at normal or 0 before you push back. Okay, and I'll show you why in a second. When you walk up and just push back, now if you were just to if you had a PCL torn and you put him in this position, it may not be apparent, but if the PCL's torn, what's lying in front of it?
ACL.
The ACL. So what if you got a torn ligament? What's in this position? What's gravity going to do? It's going to just at rest. What's it going to do? It's going to cause it to sit back, right? So if you were just to walk right up and just push back on it, would you feel any relaxity even with a torn PCL? Probably not, because it's sitting on the ACL. The ACL is taking up the slack. So to get an appropriate test, all you do is you take it, and you can typically, in a torn case, you would feel this, but you take it and you bring your knee, you pull the knee anteriorly, just a little bit, so you start to feel the condyles lined up between my thumbs, the knuckles on the femur, the knuckles on the tibia, they line up, and then I push back. Okay? So you pull anteriorly, get it set, and then push back. And it becomes a very different test. Okay? And that's a common one I know our orthopedic surgeons always get young staff with all the time, is because you just forget. You just walk around and push on it. Oh, it feels good. Then you pull it out, but you realize incorrect. So you pull it out anteriorly and push back. And hers are solid as a rock, like they should be, so they shouldn't move at all. Okay? So that's the posterior drawer test. The next one is called the posterior sag test. This is one of the high five tests. This should be an easy one. Okay? Real easy one. So all you're going to do is bend the knees here. You're going to bend them again. And just have them just rest like that. If these sag, okay, gravity, if you get a concave look to this and it matches up with the clinical signs and symptoms of a PCL test, ding ding, we got probably a torn PCL. Okay, so real simple, just positional. That's the posterior sag test. Okay, so up, if you get a concave look to it, it should look pretty flat. If somebody's got Osgood Slaughters, it'll have a little mountain on there. Okay, that's all normal, but if it starts to go concave on you and their symptoms and their mechanism is that of a PCL, it's probably a PCL tear. Okay. The next one is a meniscus test in the McMurray's. This one's got a little bit of active movement to it. So we're going to bend the knee again. Okay. We're going to grab the foot. I'm going to grab the joint line. So again, inferior pole of the patella, come down the joint line, and all I'm going to do is grind that back of the knee. So I'm going to flex it and just turn the heel in and out. That's all I'm doing. Okay. So the whole idea of that is you're going to take the knee, and when you bend it and turn it, again, where does the most of the meniscal tears occur? What portion of the meniscus? What's that? Remember there's two horns,
Posterior.
anterior, posterior horn. So the back of it. So the back portion, back curve, is where most of the tears occur. And so when you bend the knee and turn it, that's what you're basically turning on that posterior portion of the meniscus. Okay? Now I will say this test is frankly not that accurate. Meniscus tears are actually pretty hard to diagnose clinically. You usually have to do follow-up testing, and you got to see what their function is like. But if you were to read the book definition of a positive test, they're going to tell you need to hear pain with a click. I have never heard a click in 20 years, and I've seen a lot of meniscus tears. That doesn't mean you can't have a click. It's just, for me, as a definitive positive test, I wouldn't use a click as a sign of that. It should be causing some pain. Okay, it should definitely be causing. Anybody have a cartilage tear here from before? Anybody? Again, I think we have a pretty healthy group in here. I hope they stay that way. Well, if you put anybody up in that position with the cartilage tear and you start turning on that, they're not going to like you. It's plain and simple, they're not going to like you. It's going to hurt. Be very uncomfortable. But it should be corroborating your other exam. Remember, again, special tests are all the back end. They're confirming what you should already know. Okay? All right, the next one is the apprehension test. This is for a patellar dislocation or subluxation, so a partial dislocation. Okay? Now, the common question I get with this, well, if you've had a dislocated patella, wouldn't you already know that? Clinician may not, and if somebody really didn't know what was going on, they probably wouldn't describe it really well. Okay, so you do need to confirm that. So it's real simple. Just in this position, have their kneecap nice and relaxed. Again, almost all of our patellar dislocations and subluxes are going to go laterally. Okay, so all you're going to do is get a nice relaxed patella, and I'm going to push it laterally, just like that. Okay? If it's positive, they're going to get apprehensive, thus the name. They may take a swing at you. For those that have ever had this, it is unbelievably uncomfortable. If you've seen one before, they're going to sit, this is going to sit out here, okay, with the knee slightly flexed when it occurs. They're going to be screaming. It hurts, okay, just like a dislocated shoulder would. To put them back in, you just have them extend their knee, or you extend their knee, and it'll pop itself right back in. Hurts immediately, and then it feels unbelievably better. Okay, it's then going to swell up a ton after that, because you're going to definitely tear some structures. So again, they may not be able to describe that well to you post-injury when you're evaluating them. So this is, again, another way, kind of like that Thompson test with the Achilles tendon, another way to confirm it. Okay, so real simple. We're just pushing the patella laterally. Okay, if they get apprehensive, hey, stop, don't do that. I'm going to swing at you. I'm going to hit you. Don't do that again. That's a positive test. Okay, and usually if they tell you that one time, you don't have to keep doing it. Okay, then that's just going to make it matter. All right. The last two, the Balatabal test and milking test. These are for swelling. Okay, these are specific for swelling. I mentioned in class with the knee anatomy, you've got a capsule around the knee. It's got its own little environment. It's nice and self-enclosed with your meniscus and your ACL, PCL inside. So there's a difference between swelling outside of the knee or outside of the capsule and inside. We call that extracapsular and intracapsular. Okay? So we need to be able to delineate between the two. So it's really easy to walk up on an inspection, Amy's got swelling on her knee. Okay, that's great, she's got swelling. The question is, where does she have swelling? And be able to delineate between inside and outside starts to take your differentials of potential issues down. Okay? When we think of swelling inside the knee, so an acute knee injury, so she just hurt her knee. Okay, I'm not trying to jinx you or anything like that, but she just hurt her knee. When you've got swelling that happens inside the knee, and it usually happens within about 24 hours, you typically got 5 things that have occurred. 1 of 5. ACL tear, PCL tear, meniscus injury, osteochondral defect, or the articular cartilage issue, okay, or a patellar dislocation. Those are about the only 5 things you can have that are going to cause the inside of the knee to swell. Okay? So these two tests help you delineate between inside intracapsular swelling versus extracapsular. If it's extracapsular, it might be an MCL spread, it might be a bruise, might be along those lines. Okay? So the first one's a ballot-tablet test. I'll do it on this leg first. Real simple. I'm going to take my hands, bring them together around the patella. Okay? Kind of put my hands together like this. And then I'm going to take a free thumb, doesn't matter which one, and I'm going to push the patella downward. Okay? If it's squishy, okay, like a waterbed underneath it, then that's going to be a positive test. You definitely have swelling intracapsular. Okay? It should feel slight softness, but should be mostly firm. I'm pushing right against her femoral groove right now with it. Okay? So all you're doing is kind of pushing the knee together, kind of pushing the skin together, and then taking a thumb and just bouncing the patella up and down. Okay? Show it over here. Squeeze that together. You gotta bounce patella up and down. Okay? Again, if it's soft and squishy, you can usually feel fluid in there moving. That's going to be a positive test for swelling. If I was evaluating somebody that got hurt on a Saturday night, and it was on Sunday, and they came in, and that was a positive test, I'm automatically thinking ACL, PCL, meniscus along those lines. Not an MCL, so I apologize. Okay? And oftentimes, if I've evaluated somebody and they had that presentation on the field, lying on the side, fetal position, scream, all that stuff, they come in the next day and knees are fused up, it's an ACL test.
So that tells you if it's intracapsular?
It does, intracapsular, yeah, inside the knee joint. Okay. And then the milking test is for the exact same thing, just another test, and all you would do is walk up from the walking up towards the knee, up to the midline of the body. You're just going to move up above the patella. And you look, it's hard to do it with somebody, but it's an easy test to figure out. You've got a big pouch of that capsule that sits above the patella. So when you have intracapsular swelling or fusion, that's where a lot of it goes. If you've ever seen an ACL tear on an MRI and it lights up with fluid, it's always going to be up in that pouch. So this test just kind of reproduces that. Walk up and just kind of feel it kind of squishing around up top. When there's no fusion, you're basically just moving the patella and you feel the quad and skin moving. Okay? Real simple. All right? You guys break on up, go practice.